Miss Aliya to present, and you have 15 minutes, inshallah. Thank you.
Okay, Assalamu alaikum everyone. I'm Aliya Akram, and today the topic I am presenting of my research is Religion and Validation of Multidimensional Measure of Islamic Spirituality. It was a group research which was carried by me and my two group researchers, Maria and Amna, under the supervision of Ms. Rabia Dasti and Dr. Aisha Sitwat. So first of all, talking about why spirituality is important in psychology, because it is considered a governing factor, force of human life, because many of the researchers have shown that the spirituality is associated with psychological constructs, as with depression, anxiety, psychotic disorders, and drug addiction. They are negatively correlated, and it also positively correlated with self-esteem and meaning in life. After that, it is spirituality is also recognized by many of the psychotherapists that it is important in psychotherapy for the well-being of patients. Spiritual assessment is very important because it allows physicians to spot patients by stressing empathetic listening, documenting spiritual preferences for future visits, and it also allows to incorporate the percepts of patients' faith traditions into treatment plans and encourage patients to use their spiritual resources for their well-being. Conducting spiritual assessment also allow and strengthen the physician and patient's relationship and offer physicians to opportunity for their resiliency and growth and for personal renewal. Even though many Western tools have been developed, which are based on theistic and non-theistic spirituality, but they are not based on the Islamic spirituality. So in the light of this, that why Islamic spirituality is important, because Islamic spirituality is related to the Islam, a religion which is called Deen, which means the code of conduct of life. It is defined as a relationship with Allah, which results in feeling of connectedness with the divinity and sense of meaning of life and self-worth. Islamic spirituality is actually considered a multidimensional concept, which includes the beliefs, for example, that Allah is one, Holy Prophet is the last messenger, on angels, divine books, and Day of Judgment. The rituals we do on the daily basis, for example, prayers and fasting, and daily life behaviors, which are our moral values and ideals. So even though the few of the tools have been developed on Islamic concept, but they does not cater with the multi-dimensional aspects of spirituality and only cover like one aspect, for example, connectedness with Allah Ta'ala. So in the light of this literature gap, and there was a much needed measure of spirituality for Muslim population. So Ms. Rabia Dasti and Dr. Aisha Sitwat in 2014 developed an indigenous multidimensional measure of Islamic spirituality, which was grounded in Islamic perspective for the use with Muslim population. So MMIS was developed by taking into consideration Holy Quran, the electronic Hadith database, and the books on spirituality and mystical traditions of Islam. So the final version of the tool consisted on 8 domains, which were feeling of connectedness with Allah, search for divinity, tolerance and intolerance, anger and expansion of behavior, self-aggrandizement, meanness and generosity, self-discipline, and Islamic practices. It constituted on 76 items, and it has good validity and reliability. The aim of the present study was to revise the existing indigenous tool, because of that a lot of time has been passed, and to fill out the gap and modify it according to the literature and religious books, and also on the feedback of the researches which were conducted on the tool and the current time need. So to cater the linguistic and social cultural changes in the society, because in the present time, the technology has increased among youth, and even on the media, the talks about sexuality and pornography has also increased. Considering these changes in the society, the revision of the measure was required to meet the current social cultural advancement. So the method of the present study was actually it was multi-phase study. The phase 1 included a revision of the original multidimensional measure of Islamic spirituality. So the tool was revised by considering the literature and Islamic and spiritual teachings from Quran and Sunnah. The items were reviewed, modified, and some were deleted, and a few new questions were also added. The revision of the questionnaire was evaluated by 2 of the researchers for the clarity and comprehensiveness. The final questionnaire was consisted on 76 items. Total 10 items were deleted. 12 items were changed a little bit, and 11 new items were included, and 53 were retained as such. First, 2 included validation and reliability study. It actually consisted of 3 studies, which was factor analysis and validation studies. Validation study included concurrent validity, convergent validity, and discriminant validity, and then test reliability study. Sample consisted on 364 of university students with age range of 18 to 30 years, and it was collected by convenient sampling for factor analysis. And those who responded with any physical disability, psychological, mental, or terminal illness, they were excluded. The questionnaire was administered through the Google form because of the COVID situation which was going on, so it wasn't easy to get the filled form in hard form, so it was done by Google form. To establish the discriminant validity, patient health questionnaire 9 was used, and it was administered on 145 students. To establish the concurrent validity, age universal religious orientation scale was administered on 126 students, and to establish convergent validity, World Health Organization quality of life brief scale was administered on 200 students, and to establish a test-retest reliability, a test was administered on 50 students after 15 days of gap of first administration. So the procedure was, first, the permission for the research was sought from Departmental Doctoral Program Committee of Center for Clinical Psychology, University of the Punjab, Lahore. Permission to use the tool was also taken from the original authors of the tool. The Google form was created, and it included information sheet, informed consent for the participant, and the revised MMIS. First of all, the pilot study was conducted on 20 participants to see the comprehensiveness of the questionnaire, and they were asked to give the feedback if they encountered any difficulty during the administration, and if the questionnaire was reviewed and revised according to their feedback. After the pilot study, the final questionnaire was sent to teachers of different schools, universities, so they can get it filled from their students. It was also circulated in our social group. So, and when we got the responses, the students which showed any physical or psychological issues, they were excluded. And for the test-retest reliability, the questionnaire was re-administered on 50 students after 15 days of first administrations. So ethical considerations which were taken were, first, the permission from the DTPC was taken. Data was collected online, so information about the nature and purpose of research was written in the Google form. Participants were also assured of the confidentiality. Consent was also taken, and they were also told about their right to withdraw the research at any time. So the research was then was analyzed through 3 steps. First was the exploratory factor analysis. It was carried out to establish construct validity. The principal component analysis with oblique rotation method was carried out on 76 items. And the first initial analysis was conducted to find the eigenvalue of the components. Case criteria of 1 yielded 14 components, but the screen plot indicated emergence of 6 to 7 components. The 6-factor solution of PCA resulted in thematically more sound and meaningful solution, so it was retained. So the PCA placed 66 items with factor loadings greater than 0.4 into 6 components, while 10 items were not loaded in any of the factors because they had a weak or less than 0.4 factor loadings. So the factor analysis yielded 6 factors. The factors were analyzed thematically and were given name according to the contents of the item in each domain. First, the factor 1 was named feeling of connectedness with Allah Ta'ala. Second was named moral ills. Third was named moral virtues. Fourth was named quest and search for divinity. Fifth was named self-discipline, and sixth was named Islamic practices. So the factors were, first was the feeling of connectedness with Allah Ta'ala. It includes 14 items, which were related to the theme of hope in Allah for being forgiven and for better future, accountability, fear, thankfulness to Allah Ta'ala for the blessings, and belief in love and compassion of Allah. So every factor is given with 2 examples of the questions. So the items were like, I can feel that Allah is observing all my acts. I can feel the fear of Allah in my heart. The morals included 24 items related to greed, extravagant intolerance, breaking of relationship, pride, greed, self-aggrandizement, flattery, revenge-taking, backbiting, lying, jealousy, envy, making fun of others, anger, excessive talking, stinginess, lack of resolution, and cowardice. So the items were like, when I am with my friends, I make fun of others, and I tell lies to protect things that benefit me. The moral virtue factor included 9 items of generosity, forgiveness, patience, helping others, responsibility, undertaking, sincerity, and honesty. So items are, I forgive people who have wronged me. If someone oppresses me, I deal with them patiently. Quest and search for divinity, it includes 10 items related to quest for knowledge, for the search for divinity from different sources, like from Holy Quran, from Sunnah, from Islamic scholars, teachers, friends, and by contemplating on nature to find meaning and purpose in one's life. The questions are, in order to form a bond with Allah, I take help from scholars and religious spiritual guides. In order to form a bond with Allah, I exchange my ideas with my teachers and friends. Self-discipline includes 5 items related to disciplining one's everyday activities according to time. It also includes items of sluggishness. So items are, I am unable to complete the work I set up for, I am inconsistent. Islamic practices included 4 items of praying, reciting Holy Quran, zikr, and fasting. I recite Quran Pak, and I pray or observe namaz. So these are the tables showing the results of discriminant, convergent, concurrent validity, Test-Retest reliability, and internal consistency. The patient health questionnaire 9 showed negative correlation with all the subtests of tool. We show that the discriminant validity was established, and the depression and spirituality are negatively correlated. While with the physical health, psychological well-being, social relationships, and environment, the subtest of the tool are positively correlated, except the Islamic practice, which is negatively correlated with physical health. All others are positively correlated, which established the convergent reliability of the tool. And for the concurrent validity, intrinsic religiosity orientation scale was used, which also showed positive correlation between subtest and the tool, and it established the concurrent validity. The test-retest reliability also correlation between test and pretest was also evaluated, which ranged from 0.73 to 0.94, and it showed that the test has test and retest reliability, and alpha compact values showed internal consistency, which ranged from 0.65 to 0.95, and it shows internal consistency. In conclusion, the revised indigenous multidimensional measure of Islamic spirituality as a valid and reliable tool to assess Islamic spirituality in Muslim adults. And for the future research, the tool can be used to evaluate relationship with other psychological constructs such as anxiety, hope, and optimism as metaform disorders. And it can be conducted on different populations with different demographics to confirm the confirmatory factor structure of the tool. And as it is also evident in the literature that spirituality is very important in therapeutic interventions. So it can be also used in clinical setting to evaluate strengths and weaknesses of the clients, and then to devise the therapeutic intervention on a species. Further, Islamic concept can be integrated in the CBT or other therapies, and its efficacy can be evaluated by using this tool. The limitation of this study was that in the previous tool construction, madrasa students was also included, but this time due to COVID situation, they couldn't be included in this in the research. So in the future research, they can also be considered for the administration test. Thank you so much. These are the references. And
Jazakallah khairan, thank you for that excellent presentation. So I just want to reiterate to both the audience in person and online that we'll be interested in questions at the end. So if anyone has any questions for our speaker that they deposit them in the Zoom chat in person. If anyone has questions, we request that they write them down over here on card, and we'll read them out in the discussion session, inshallah. Excellent presentation. We request that you quit your screen share so that our next speaker can begin sharing their screen, inshallah. Jazakallah khair. So our next speaker is going to be Ms. Javeria Arshad. We request that Ms. Javeria begin her screen share so that she can start her presentation. I'll just give a brief bio before we begin. So Ms. Javeria Arshad is from Pakistan. She has done her bachelor's in psychology from the University of Gujarat, Pakistan, and is currently enrolled in a master's in clinical psychology at the Center for Clinical Psychology at the University of Punjab. She's also working in the Center for Clinical Psychology in Lahore as a trainee clinical psychologist and has experience in child and adolescent psychiatry. We welcome Dr. Arshad to share her expertise with us, and we remind her that she has 15 minutes to speak, inshallah. Jazakallah khair. Thank you.
Assalamu alaikum. I hope I'm audible. Can I presentation?
Yeah, we got you loud and clear.
Okay. So, Assalamu alaikum, everyone. I'm Javeria Arshad, and my topic of presentation is Scrupulosity at the Crossroads of Faith and Psychopathology. First of all, I want to introduce the key elements of my research. Starting with the OCD, it is a pathology, as you all know. It's a pathology that is marked by the presence of obsessions and compulsions. The persistent obsessions are basically the persistent and recurrent thoughts, impulses, urges, and images that are intrusive and unwanted in nature. And compulsions are basically the repetitive will to perform in response to those obsessions. Obsessions and compulsions comprise religious themes, excessive religious behaviors, irrational doubts and fears regarding sin, and hypermorality. Then we term it as scrupulosity. When we reviewed the literature research features of it that highlighted the need and importance of research on this topic, for example, when we reviewed the prevalence of scrupulosity, we came to know that it is one of the most common forms of obsessions. The substantial portion of OCD patients within the range of 5 to 33% suffer from scrupulosity. If we review the relationship of scrupulosity and OCD, we came to realize that it is, although it is characterized as the subtype of OCD, but it possesses some distinctive features. If we closely observe the relationship of religion and scrupulosity, research evidences suggest that the exhibition of persons' obsessive compulsive symptoms might be influenced by beliefs and code of conduct of certain religions. Religious OCD is reported to be relatively predominant in societies that are religious, especially conservative Muslim countries, and missionary schools report much larger instances of these psychopathologies. If we review the culture and the relationship of culture and scrupulosity, we came to know that the presentation of OCD symptoms can be influenced by an individual's culture. If we overview the therapeutic stance regarding scrupulosity, we came to know that it has a poorer treatment outcome. Religious-based interventions are found to be most efficacious in dealing with such patients. Clients view their symptoms as a domain of religion and psychiatry, so collaboration with religious scholars can prove to be most effective in dealing with such cases. Further studies confirm that roundabout, if we specifically study the study by McIntyre, 738 participants of different religious affiliations ranging from 18 to 72 years of age were studied. Based on the odd ratios, participants who identify as non-religious were found to be 1.86 times less likely to endorse scrupulosity than those who are religious. Moreover, scrupulosity was found to be more disabling as compared to the other forms of OCD. Other studies also confirm that regarding the treatment interventions and other things, religiously integrated approaches were found to be most efficacious. Specifically, IERT proved to be most efficacious among other forms of treatment. A study conducted by in in 2011 explored the themes of OCD. 50 Muslim patients were examined in the study, and the results of the study illustrated that 60% themes were religious in nature. Another study was conducted by Ishfaq Malik and Batul, which explored the experiences of Pakistani psychologists and cognitive behavioral psychology. A psychologist was taken as a sample. Thematic analysis highlighted the exceptional efficacy of some CBT techniques, while highlighted less efficacious were other techniques highlighted less efficacious and abundant ones. If we talk about the significance of the study, clinical researchers suggest that substantial number of OCD patients within the range of 5 to 33% experience scrupulosity. However, despite of having a deep-rooted history, it has not received due attention in clinical dialogue. The exhibition of persons obsessive compulsive symptoms will be influenced.
Assalamu alaikum, Dr. Javeria. Dr. Javeria, I'm terribly sorry to interrupt you, but some of our Dr. Javeria.
Religious OCD is reported to be relatively predominant in societies that are religious. OCD symptoms can also be influenced by individuals' culture. After it in 1975, 46% were occupied, 46% of the population or the occupied with incarnation, and it was that social culture background was significant in the societies are in general are more occupied with the matters related to purity and climate. There's also an open debate regarding. Yeah. Can you? I can hear you.
I'm terribly sorry to interrupt you. Some of our panelists are having, some of our attendees are having difficulty hearing you. Could you just check your internet connection and make sure that everything is stable, because your voice was fading in and out. Once again, I'm sorry to interrupt you.
Can you hear me?
It's slightly better now. Also, Dr. Javeria, would it be possible for me to share from my screen, because on our current screen share it's a bit small for the audience to see, if that's okay with you. Dr. Javeria, can you still hear us?
Okay. Okay, you can share it. Yes, I can hear you. You can share your screen.
Yeah. So I'm sharing your slides now, inshallah. So I'll just share from my laptop and you can kind of guide me up and down, inshallah. Just feel free to stop me when I get to the slide that you're at.
Right here.
All right, perfect. Thank you. Please resume. Thank you so much.
Significance. Next slide, please. Okay. Okay, clinical research suggests that a substantial number of OCD patients within the range of 5 to 33% experience scrupulosity. However, despite of having a deep-rooted history, it has not received due attention in clinical dialogue. The exhibition of persons' obsessive-compulsive symptoms might be influenced by beliefs and code of conduct of certain religions. This is particularly true for scrupulosity. Religious OCD is reported to be relatively predominant in societies that are religious, for example, conservative Muslim countries. The presentation of OCD symptoms can be influenced by an individual's culture. For example, a research conducted by Akhtar et al. In 1975 illustrated that 46% people were preoccupied with dirt and contamination, and it was suggested that the socio-cultural background was significant in this respect, as Indians in general are preoccupied with matters related to purity and cleanliness. Next one. There's an ongoing debate about the characterization of scrupulosity as a separate clinical disorder because of its unique clinical features. Limited research on many psychiatric disorders from the religious and cultural viewpoint, despite Islam being one of the major religions in the world. Clinical psychologists report difficulty in treating scrupulosity. However, the exact nature of the challenge with respect of certain scrupulous content is unclear and warrants investigation. The presence of religious symptoms in OCD predict poorer treatment outcomes according to some studies. For religious patients experiencing scrupulosity, religious-based interventions like religious CBT could significantly enhance prognosis. The aim of the present study was to explore the experiences of Pakistani clinical psychologists in dealing with scrupulosity and how scrupulosity is manifested in Pakistani culture. Based on these findings, collaborative, religiously integrated therapeutic guides and self-help manuals can be designed by integrating erudites and psychologists' perspective. Next one. Research method. The current exploratory study was based on the basic and generic qualitative research design. Research questions. The purpose of the study was to explore different dimensions of scrupulosity that are prevalent in Muslims of Pakistani culture. Following research questions were dealt in this study. What are the different dimensions of scrupulosity indigenous to personal patient's belief system in Pakistan? What is the clinician's experience in treating scrupulosity? What is the role of religion in society in shaping scrupulosity? Next, to explore around the phenomena of scrupulosity indigenously in Pakistani culture, social constructivist paradigm was deemed to be most suitable. Sampling strategy was basically non-sampling strategy. Specifically speaking, snowball or chain sampling was used. Next one. Sample size, 10 clinical psychologists were included. However, efforts were made to ensure that the data saturation and data sufficiency was criteria of data saturation and data sufficiency were met. Participants, if we talk about the inclusion and exclusion criteria of the research, the inclusion criteria of research was the participant recruited for the current study were based on their professional fields of specialization. The study included clinical psychologists, a professional degree, ADCP, MS or PhD in the field of clinical psychology. Experience in dealing individuals with scrupulosity, a minimum of 10 years of practicing experience was used as a inclusion criteria. Exclusion criteria was basically experts without institutionalized educational degrees and without expertise in dealing with OCD were not included in the study. Psychologists who were not currently working in clinical settings, either in private or government sector, were excluded. Those psychologists who lack experience in dealing with OCD were also excluded. Next one. If we specifically talk about the procedure of the study, permission was firstly sought from the Departmental Doctoral Program Committee, DDPC, to conduct the study, following which the prerequisites for data collection was carried out. The literature-based demographic questionnaire was finalized to meet the inclusion criteria for the current study. A semi-structured interview protocol was developed. The construction was followed by the scrutiny and evaluation by 5 professionals, 2 mental health practitioners, 3 experts in qualitative research. Their suggestions were catered in modifying and improving the structure of the protocol. After finalizing the measures for data collection, 2 mock interviews were conducted with clinical psychologists to assess the comprehensibility of the questions in the interview protocol, following which well-situated professionals such as clinical psychologists were approached for the recommendation of professionals who could meet the stringent criteria of the study. A list of professionals were generated. The names repeated were of most significance. Professionals with publication citing in abundance and those who were active in dealing with OCD were given due consideration. These participants were then further inquired of experts in their circle having abundance of information to be shared, hence following the snowball sampling criteria. Permission letters were sought from the director of Center for Clinical Psychology to approach the desired selected candidates. Consent was taken from each participant verbally and in writing. Participants were ensured about complete confidentiality of information. Site and time were negotiated for data collection, and consent was sought for voice recording during the data collection phase. 60 to 120 minutes in-depth interview was conducted at the predetermined site with each of the experts. During the interview, field notes were taken by the researcher. The second phase included checking for missing, vague, and fragmented information that was scattered in an additional follow-up session for elaboration and clarification. Next slide. The data collected was then transcribed and taken towards the stages of analysis. Next. Ethical considerations. If we talk about the ethical considerations, firstly, professional ethical codes and standards were given due consideration. Departmental approval of Departmental Doctoral Program Committee was taken. Permission from the respective authorities were taken. Standard operating systems or SOPs were followed. Informed oral and written consent was taken. Thorough debriefing was done. Confidentiality was assured. Coding of data, presentation and analysis of data was done genuinely. Data verification. Following data verification techniques were used to ensure the validity of obtained data, prolonged engagement, thick descriptions, peer review, and epoch. Next one. If we talk about the results of the current study, several themes was extracted from the study through a tiresome process of data transcription, coding, and in-depth analysis. These themes help to explore different aspects of scrupulosity and specifically delve into the research questions of the present study. Major themes emerged from the study were initially characterized in 3 different dimensions linked to different research questions about the dimensions of obsessions and compulsions in scrupulosity, role of society and religion, and nature of aspects of treatment of scrupulosity. As themes represent an organized pattern that is arranged around a central core construct, so keeping in view 3 major distinct and overarching superordinate themes were identified, which comprised multiple main themes and sub-themes incorporating diverse codes that somehow belong to similar domains. Overarching themes of the study were Waswasa al-Kahri, overwhelming whisperings, was characterized under manifestations of scrupulosity, which incorporates the main themes of Sab and Shatam, Paki Falidi, existential dilemma, a road that leads nowhere, and pathological doubts. Another major theme was characterized under the role of religion and society as predisposing scrupulosity, which includes main themes of religious orthodoxy, inoculated devoutness, role of religious inclination, and societal denunciation. An additional superordinate theme was placed under treatment domain, being assist of treatment, which further included 3 main themes as a hard nut to crack, Islam, an antidote, and a nature of treatment. On the whole, total of 11 main themes emerged from the research incorporating several sub-themes. Next. first major theme, overarching theme that was emerged from the study was
Dr.
predisposing.
Javeria, I'm sorry to interrupt you. Just a respectful reminder that you have 1 minute left. Thank you.
Okay. The first major theme was predisposing scrupulosity. This overarching major theme incorporates the factor that increase individuals' vulnerability towards scrupulosity. This theme emerged where participants were asked about the role of religion and society in developing scrupulosity. All patients underscored the crucial role of religion and society in different ways, along emphasizing other factors. The superordinate themes included a number of main themes, which included religious orthodoxy. The sub-themes included in this main major theme were excessive claiming, religious understanding, immoderate punishment, religious ritualism, distorted perception of sin, role of religious inclination, inoculated devoutness, and societal denunciation. The second overarching theme that emerged from the study was Waswasa al-Qahri, overwhelming whisperings. This superordinate theme entails all obsessional thoughts which are either scurrilous or deemed immoral in nature. It includes thoughts of insulting, speaking scurrilously, or showing contempt to or lack of reverence for God, his prophets, and sacred or holy entities of Islam. It also includes sexual images and thoughts regarding religious figures. This theme will also emphasize the pathological doubts regarding violating moral standards, questions regarding existing and feeling of resentment towards God. This theme includes following sub-themes: sub and shatam, God, sub and shatam, iniquitous sexual fantasies, God, punitive and implacable, taki palidi, existential dilemma, a road that leads nowhere. This sub-theme this theme also entails two sub-themes, which includes existential crisis and omnipotence, or kun fayakun. The last sub-theme of this overarching theme was pathological doubts, which includes doubts related to religious matters, doubts of apostasy, improper performance of religious rituals, and confusion regarding the intentionality of thoughts and moral transitions. The last theme, a major overarching theme of the study, was essence of treatment. This theme emerged when questions about the treatment was raised by the interviewer. It highlighted that scrupulosity is not an easy to deal with type of disorder. It is much complicated, and practitioners in field encountered numerous difficulties in dealing with it. It is also highlighted that the commonly used therapeutic approaches in the field. The main theme was basically a hard nut to crack. Sub-themes that included in this theme were not an easy game, higher dropout, poor compliance, the crucial knowledge. Another main theme that emerged from this theme was nature of treatment. That includes the sub-theme that was first line therapeutic interventions, the approaches. CBT was found to be the first line therapeutic approach to deal effectively with this type of disorder. Gold standard techniques, which was found to be ERP and the model of Andrew Wells. Islam as an antidote. This sub-theme encompasses the positive remedial role of Islam in dealing with patients of scrupulosity. Almost every patient of the study emphasized the pivotal role of Islam in treating scrupulosity. It was highlighted that if the distorted perception about Islam is changed, the deep-rooted schemas behind scrupulosity can be altered. If we talk about, can you open my last slide, please? Second last.
Dr. Javeria, so we're actually out of time, unfortunately. I'm very sorry to cut you off. We'll have some time in the discussion if you'd like to resume, but I want to make sure that we give our other panelists a chance to speak as well.
Okay. Jazakallah.
Jazakallah. Assalamu alaikum. So our next speaker will be Ms. Farah Islam, who is the director of the psychospiritual department at the Yaqeen Institute for Islamic Research. We'd like to welcome Ms. Farah, and Ms. Farah, would you like to share from your screen, or would you prefer to from mine? It's up to you. I'll leave that to your discretion.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm actually sharing from my screen, so hopefully you can see that.
Perfect, thank you. So just a reminder to the audience, if anyone has any questions for either the previous speakers or our current speaker, Online audience, please deposit in the Zoom chat and we'll get to it in the discussion. In-person audience, if anyone has any questions, they can write them down on this card. And without any further ado, we give Ms. Farah the floor to speak for 15 minutes, inshallah. Jazakallah khair. Thank you.
Assalamu alaikum. Jazakumullah khairan to everyone here for having me at the conference. You know, I do miss being there in person, was there for Arizona, so I'm really missing out being with all of you here there in person, alhamdulillah. So I wanted to share some research that we've been doing at the Yaqeen Institute for Islamic Research. I'm Dr. Farah Islam. I'm the director of the psychospiritual department there. And so our work really, this particular work has been looking at the role of religiosity and in regards to Muslim mental health. And so, of course, this conference and everything that all of us are within this field of research is sort of predicated on this idea that there is this construct called Muslim mental health, or this idea that faith is related to mental health. But of course, you know, a lot of that research in this domain has been on Christian samples or on other religions and not on global or large samples of Muslims. And so this research really wanted to work more with that and really test that theory. And so, of course, to introduce, you know, Allah subhanahu wa ta'ala in the Quran has told us, مَا أَنزَلْنَا عَلَيْكَ الْقُرْآنَ لِتَشْقَى. You know, we have not revealed the Quran upon you to cause distress. And so, of course, the corollary being that Allah subhanahu wa ta'ala sent us the Quran to bring us comfort and contentment. And the Quran then is then, of course, and our deen, and our faith, is at the very center and the heart of our conversations about Muslim mental health. And so then what is mental health? And of course, everyone's already in this field, but of course, the UN has put forth this idea of mental health being the state of well-being, you know, where you realize your own abilities, you can cope with the stressors of life, etc. But of course, you can understand that there's something very critical missing that seems to be really important for us as Muslims, and that being the piece of religiosity or of faith or of spirituality, right? While most definitions of mental health talk about, you know, this sort of biopsychosocial model, right? Talking about biological factors like genetics, psychological factors like trauma, or a person's personality and psychology, etc. And then, of course, other factors like the environment or social determinants of mental health. But again, that critical piece of religiosity and spirituality is often left out of those conversations. And so we wanted to talk about, you know, can we problematize that? Can we reconceptualize this idea of mental health, particularly for Muslim populations? And so just like Dr. Akram has been working on this sort of multidimensional measure of Muslim religiosity, we also at Yaqeen have developed something like that as well. So it has 6 dimensions. We called it basic. So the B coming from belief, and we also measured attitudes, spiritual connection, institutional connection, so your connection to the masjid or to the ummah, or to the mosque, I mean, and contribution. And so all of that together, those 6 dimensions being sort of our multidimensional measure of religiosity, because generally speaking, one of the big gaps in the literature is that oftentimes when religiosity is measured in a study, they just measure using very limited constructs, like, you know, frequency of worship at the of masjid or mosque or place of worship attendance, or a person's self-reported level of religiosity. Again, just like a one item type of measure, and it's very limited. So we really wanted to, again, encompass that idea of, you know, our faith is our deen. It's a whole way of life. And that's really, unfortunately, not captured by these limited constructs.
Dr. Farah, I'm tremendously sorry to cut you off, but our attendees can't see the slide that we're on. If possible, could you kind of scroll down?
Oh, it is on that side. I'm just going to stop share and try again.
Oh, okay. Thank you.
Sure. Can you see that now? No?
Yeah, that's better. Thank you so much.
Okay, sure. Sure, Jazakallah khairan. Sorry, that happens sometimes for some reason. There might be just a lag in the internet. So this is our sort of our measure, our holistic measure of religiosity. And in addition, we also wanted to measure further psychospiritual variables within our sample as well, that being uncertainty and tolerance. So this idea, sort of a psychological measure of how tolerant a person is towards change or towards uncertainty. And so generally speaking, this is something that really has been magnified, for example, during the pandemic, right? A lot of us were thrown into an extremely uncertain situation, something we've never experienced before. And how did you respond to that? Was that stressful? Were you able to roll with all the changes and all the difficulties that came with it? And so many people, for example, would rather have greater control, need more control, need to have more certainty. And then, of course, in those types of uncertain situations, as most of life is, of course, uncertain, they really do struggle. So uncertainty and tolerance was one psychospiritual variable that we wanted to look at, as well as that of religious doubt. And again, there is a lot of research on religious doubt, but with Christian samples. And so we really wanted to look at the role of religious doubt in Muslim mental health. So just to move on to our methods then, so we had a really large global sample of 3,551 Muslims across the world. We had, in addition to socio-demographic variables, we also measured psychospiritual variables that we just talked about. So we measured holistic religiosity using that basic survey, of religious doubt, as well as uncertainty of intolerance. Then we had two measures of psychopathology, depressive symptomology and anxiety symptomology using the PHQ-2 and the GAD-2. And we just wanted to really talk about the importance of, mental health not being sort of just the absence of mental illness or sort of very limited definitions that we often see. So we wanted to talk about mental health being both psychopathology and positive mental health as well. And so our positive mental health outcomes then were the life engagement test, life satisfaction, as well as mental well-being. And so that we had 5 mental health outcomes in the study. So moving on to our results, inshallah. Just to give you an idea of what our sample profile looked like, the majority of our participants were in North America. The majority identified as South Asian. The majority were women. The majority had at least a bachelor's degree or a master's degree, and the majority were single, never married, and most were in the 25 to 34 year age group. Moving to the results then, inshallah. So as of course we use the PHQ-2 and the GAD-2, which has they both have high false positive rates. Generally speaking, about a quarter to almost a third of each group was flagged for depressive disorders or for anxiety disorders, respectively. And again, the false positive rate is very high, so most people who were actually flagged may not necessarily have those disorders. It's just that because the measure itself is just a 2-item measure, so it's limited in that ability. So then we also did multivariable regression analysis just to understand, what were the variables actually associated with those 5 different mental health outcomes. And so you'll notice here that, while we had socio-demographic or social determinants of mental health here, we also had those psychospiritual variables as well that we added into the model. And particularly, I just want you to focus on the impact or the contribution of religiosity as well as of uncertainty and tolerance. So UI is uncertainty and tolerance. And you'll notice here that their contribution compared to all the other variables in the model were much greater. They were stronger predictors of all of our mental health outcomes. And we'll talk about that more. So in terms of social determinants of mental health, older age and being married, this is something, of course, we've seen established in the literature, were generally associated with better levels of mental health, as well as women had higher rates of depression, anxiety, and lower levels of well-being. Moving to those psychospiritual and religiosity types of variables. So religiosity was predictive of lower depressive and anxiety symptomology and higher life purpose, life satisfaction, and well-being. Religious doubts were also related similarly with psychopathology and lower levels of life purpose and life satisfaction, while uncertainty and tolerance was related to all of our 5 mental health outcome variables. And so this is just a nicer visualization of those results. So just for you to be able to read those. So we're looking at those standardized beta coefficients. So any coefficient or any variable that you see crossing the line means that it's not significant in the model. And the further any any variable is from the line means the stronger it is as a predictor. So you'll notice here, right, most of the variables are kind of around the line, but uncertainty and tolerance, when we're looking at the variable of depression, is this the strongest predictor of depression. And then also when we look at our next psychopathology variable of our mental health outcome of anxiety, again, the strongest predictor was the psychospiritual variable of uncertainty and tolerance. And then if we look at when we have 3 positive mental health outcome variables as well, so well-being, here religiosity and uncertainty and tolerance, you'll notice were the strongest predictors of this mental health outcome. Similarly as well, life purpose, both religiosity and uncertainty and tolerance. And again, none of the other socio-demographic or the social determinants of mental health, none of the other variables really could compare in the strength of its in comparison to these variables and to these predictors. And again, our last positive mental health outcome was of life satisfaction. Again, religiosity was the strongest predictor of life satisfaction. And so, so just to summarize again, religious and psychospiritual factors were the strongest predictors of Muslim mental health. So if someone wanted to sort of ask, you know, is faith, is deen, is spirituality or religiosity really actually important to Muslim mental health? Yes, you can say that, yes, we do have evidence now, you know, on a large scale that yes, subhanAllah, it is really important. Religiosity was the strongest predictor of those positive mental health outcome measures that we had. While on the other hand, uncertainty and tolerance was the strongest predictor of psychopathology. And so there are really interesting, important implications for this. And so the major sort of takeaway message we want everyone to understand, of course, is this idea that religiosity and mental health are linked for Muslims. And religiosity really does play a central role in Muslim mental health. And so when we talked about, you know, what is mental health, that state of well-being, et cetera, that the UN put forth, then we want to put forth, you know, maybe we can try to figure out a new definition, a new idea for it. You know, what is Muslim mental health? What does that mean? And so we're basically trying to put forth the idea then that Muslim mental health can be reconceptualized more holistically to include religious factors and psychospiritual factors as well. And we hope, inshallah, there can be more, you know, large-scale Muslim studies that look into the contribution of religiosity and these psychospiritual factors into mental health. And particularly the clinical implications are obviously so important and so interesting. And so our real recommendation here then, if there is that, you know, that synergy and that connection between religiosity and mental health for Muslims, then of course then our recommendation we're putting forth is this idea that spiritual care or those working in faith spaces need to really be working together in collaboration with mental health professionals, right? That's where that bridging can occur. And so, for example, so remember one of our findings was this idea that uncertainty and tolerance, that psychospiritual variable of uncertainty and tolerance, was the strongest predictor of psychopathology. And so, for example, let's say there is an imam and a congregant comes to them experiencing difficulty with the qadr of Allah, with the will of Allah. And you can understand here then, of course, the will of Allah and having difficulty accepting the will of Allah is related to uncertainty and tolerance, right? Anything related to tawakkul, having trust in Allah, etc. There are a lot of spiritual elements within uncertainty and tolerance. And so if that imam is working with someone who is having difficulty with uncertainty and tolerance, then you could imagine then they may also need mental health counseling or need help, right? Because we saw that uncertainty and tolerance was often very predictive of depression and anxiety. And so in this situation, what would be best would be for the imam to be able to refer out to a therapist, to Islamic psychology, etc., and to have that collaboration be possible. And then on the other hand, we found that, remember, that religiosity was the strongest predictor of positive mental health outcomes for Muslims. And so on the flip side, if a therapist is working or a counselor has a Muslim client who's experiencing low life satisfaction or low well-being, any other measure of positive mental health, and they're just feeling low on life satisfaction, for example, then in that case, something that might be helpful would be to boost religiosity for that person. And that might happen by, whether the therapist could then recommend that they get connected to their mosque or start volunteering within their community, or they could refer out to an imam, to a chaplain, to someone who works within that spiritual care space. And so you can see how that idea of those working within spiritual care, working in tandem with those who are working in mental health care, really is sort of the best way to ensure sort of the mental health and the spiritual well-being of Muslim populations. And so, of course, just to end with that idea that we really hope to put forth this idea that we do need to reconceptualize our ideas of Muslim mental health to include religiosity and psychospiritual factors. That is really the best way for us to be able to ensure the psychological and spiritual well-being of Muslim populations across the globe, inshallah. So jazakumullah khairan. I really appreciate your time, and looking forward to your questions, and an early Ramadan Mubarak to everybody here. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam. Jazakallah khair, Dr. Islam, for a thoroughly illuminating presentation. And we look forward to kind of getting back into this in the discussion after Dr. Mahdi speaks. In the meantime, we'd like to welcome Dr. Mahdi. I'm just gonna, Dr. Islam, if you could just quit your screen share so that we could, thank you.
I have quit screen share.
Jazakallah, thank you. So Dr. Mahdi Qasqas is our next speaker. Dr. Mahdi, if you could just engage your screen share so that you can share your presentation with us. A brief bio before we begin. Dr. Mahdi Qasqas is a psychologist and researcher with over 20 years and 1,500 service hours as a volunteer, khatib, and community leader. Drawing on his expertise in Muslim mental health, he mentors and trains current and future mental health practitioners. Using his Islamically integrated practice and ethical framework, a byproduct of his trademarked psychospiritual first aid consultation model, and we're extremely grateful to have him here. So Dr. Mahdi, if you could take the stage.
Assalamu alaikum wa rahmatullahi wa barakatuh, everybody. Dr. Islam, jazakallahu khair for the presentation. Dr. Akram, Dr. Arshad, I'm sitting here and I'm thinking, I don't even want to present. I just want to talk. I want to discuss. I think you guys have done such an amazing job. The research, the effort, and the that rigor. May Allah subhanahu wa ta'ala accept it, inshallah. These presentations, the virtual teleconference, since COVID, I think it's affected everybody in terms of having to pivot your practice, you have to adapt, right? In therapy, when conversations happen over the phone, some of the things we commonly hear in conferences are probably the worst thing to hear. Like, can you hear me? Are you still there? And so we got to adapt our style to build something so essential to the therapeutic outcomes, which is the therapeutic alliance, the relationship. Like, for example, I don't even know who I'm talking to. So I would have loved if you shared your screen so I could see the audience, right? And Dr. Islam, you're the only one I can see here. So it's a lot easier for me to communicate with an individual when I'm able to adapt to their preferences. I'm able to adapt to the nonverbals. There's so much communication. Oh, yes, wonderful. Excellent, thank you. But here's the problem. Now that there's 3 or 4 people, I'm jumping back and forth. So when I give khutbahs, for example, often the khutbah is supposed to be relevant to the audience. And sometimes we don't know if somebody's actually engaged or not, if they can't tell us. So when it comes to the topic that I chose today, I called it from ha-ha to Aywaaa, all right? But if you're not an Arabic speaker, Aywaaa is perhaps the equivalent of acha, or tik-tak, or yes, or aha. There's a difference between Aywaaa, as yes, and Aywaaa, You know that moment when you, I get it. There's something going on at a cognitive level that it just resonates, it clicks, So for example, when I'm looking at Dr. Akram's presentation, I'm like, yes, multidimensionality, 100%. Dr. Arshad, when you're talking about OCD of the Islamic variety or scrupulosity, I'm thinking absolutely, waswas al-qahri, 100%. And then Dr. Islam comes, just knocks it out of the park and says, hey, look, guys, you want to take Islam out of something, it's no longer, you want to take Allah out of something, it's no longer Islam. And likewise, if you take the relationship out of therapy, it's no longer therapy. So there's so many essential features that have been brought up that makes it nearly impossible to put a full comprehensive taxonomy of all of the variables that are involved in adapting to the client's preferences, right? Adapting to the client preferences is essential for evidence-based practice across medicine, social work, psychology, all of it, right? But how do you do it? Furthermore, there's a lot of studies, meta-analyses of RCTs that adapting to the culture, religiosity, spirituality of the client far supersedes, it's more efficacious than conventional treatment, okay? So this is what we know, but how do you do it? So we know that the therapeutic alliance is, in common factors literature, possibly the most important variable that you have control over in therapy to lead to positive therapeutic outcomes. But how do you do it? We know that integrating religiosity and Islam into therapy is essential, but how do you do it? This is where Dr. Farah, when you talked about, utilizing the imam as well as the mental health professional, wouldn't it be awesome if we can take some of the amazing activists in the Muslim community, train them to be lay counselors? Because I promise you, they would have a lot more ability to establish a positive therapeutic alliance than most people will. And part of the reason for that is their ability to pivot, to adapt, right? So what I'm going to share with you is literally the first 15 seconds of so many of my sessions. And the reason why I decided this topic above so many others is because it's a presentation. If I was to jump into my Sunnah-based practice framework and talk to you about the localization method and how it's going to bore me and you, right? Well, it won't bore me. I'll nerd out on this for days, right? But the idea is I want to just give you the first 15 seconds of a normal therapy session over the phone, okay? With a Muslim client. And it doesn't matter what the diagnosis was or the presented concern. What matters most is the idea of how do I adapt to their preferences, okay? Now, before COVID, it was a lot different. Person would come in, they would be greeted. They wouldn't be greeted with a consent form. They'd be greeted by my staff. Assalamu alaikum, come on in. They'd be seated. Would you like some tea? No, I'm okay. Coffee? No, it's okay. Zuhurat, different types of tea. They'll keep saying no. We'll say fine, coffee. They'll say no, it's okay, tea. That banter, that back and forth, because hospitality is an essential feature of the culture of my office, all my staff. So this way, you're adapting to a person's humanity. Everybody loves to be treated with respect and feel hospitable. But how do you do that over the phone? Hey, would you like some tea? Yeah, so go make it yourself. So you got to come up with different alternatives. So this is kind of how it goes, all right? Ring, ring. Assalamu alaikum wa rahmatullahi wa barakatuh. Now their response, wa alaikum assalam, tells me something. Wa alaikum assalam wa rahmatullahi wa barakatuh tells me something. Wa alaikum assalam tells me something. Or hi tells me something, right? So from that point, I'm pivoting to the next question, to the next thing. Usually, let's assume they said, wa alaikum assalam. I don't know at this point, are they religious? Are they not religious? Do I adapt it religiously, culturally? What's going on? So the next thing I say usually is, alhamdulillah as-salama, alhamdulillah for your wellness, insert referral concern here. I heard, your doctor referred you to me for, you got into a car accident. I hope you're okay. How are you doing? Okay, this is typical. Their response would usually be what? Somebody asks you, how are you doing? You're a Muslim. What do you normally say? Alhamdulillah. Okay. So then I respond to that. Alhamdulillah ala kulli hal. Okay, alhamdulillah for everything. Their response also tells me more about themselves. Remember, this is the first 5 seconds. If they say, وَالنِّعْمَ بِاللَّهِ alhamdulillah ala kulli hal, or I love when the older women say, yes, brother, salam, jazakallah khair, alhamdulillah, yes, everything. I say, alhamdulillah ala al-khairi wa shar, right? Like, yes, alhamdulillah, good and bad. Coming from the hadith of the Prophet Muhammad sallallahu alaihi wasallam, alhamdulillah ala kulli hal, coming from the essential feature of our faith, qadar, right? Qada' qadar. This is a pillar of faith. Imagine if I just stopped there. Now, my client, I might be activating the uncertainty and tolerance, activating this notion of, oh my God, if I even start talking about my problem, am I violating my faith? Is this haram? If I stopped there, I would have literally engaged in spiritual shaming, conversation killing, destroyed the alliance, right? What more can you say after that? If somebody says, alhamdulillah, for the good and the bad, what are they supposed to say? No, I actually wish they would say, I don't believe that, right? Because it gives me an indication that there's some cognitive restructuring that needs to happen. So this is what I say. Hati shar. Give me the shar. This almost always leads to a chuckle. Imagine because they're assuming that we're going to get into this typical, no, you shouldn't complain. No, depression is haram. Fani manak. All of these things that every one of you understands what not to do. The only problem is, without training, it gets very difficult. Sometimes we resort to these cliches. Sometimes we jump quickly in trying to give advice. But you see, the difference here is that advice is saying the right things. Counseling is responding to the right things. And when the Prophet Muhammad sallallahu alaihi wasallam said, لِكُلِّ دَاءٍ دَوَاءٍ فَإِذَا أُصِيبَ الدَّاءِ الدَّوَاء بَرِئَ مِنْهَا بِإِذْنِ اللَّهِ تَعَالَى, right? For every problem, there's a solution. If the problem and the solution are matched, then by the will of Allah, the person will be cured from it. Take a look, take that concept and apply it to this matching process, matching the diagnosis with the proper treatment, matching the right counsel with the right client, all of these variables. What I'm putting forth here is matching your style to the preferences, culture, and religiosity of the client. Sometimes it's easy, simple, clear, but don't assume just because they said wa alaykum assalam, alhamdulillah, that automatically they're religious. That comes later. The understanding of their deeper nuances comes a little later. But this concept, alhamdulillah ala al-khairi wa shar, hati shar, give me the shar, it does something. This is the Aywaaa moment. Oh, wait a minute. Yes, I can talk about this. I don't know exactly. I haven't done any rigorous analysis of it from a research perspective, but I've done tons of, I call it concurrent credibility. Basically, I can speak about the exact same thing from a secular perspective, marshaling the biological and the cognitive, affective, social, cultural basis of behavior, while at the same time speaking about it purely from an Islamic evidence point of view. This is what makes it evidence-based. This is what makes it's flexible enough to be trained. And this is just one indication, the first 15 seconds. Now, I don't know if I'm out of time, but I don't want you guys to lose the opportunity to ask questions of the speakers and us to have that dialogue. But it's clear in my mind that being able to adapt your style to the preferences, culture, and religiosity of the client is evidence-based practice. How to do it, it's a different story. That's why, alhamdulillah, we have these conferences. We start picking up from one another. But one thing is certain. If the client does not feel comfortable in the first 15 seconds, the first 15 minutes, there's a big problem there. If they have to explain themselves too quickly, there's a problem there. If you get into goal planning immediately, there's a problem there. So I teach this Qabul model where salam, ta'aruf, shura. There's this sense of peace, then there's this sense of understanding, then there's this sense of goal planning, right? And in each one of these interactional projects, if you've accomplished this phase and move on to the next one, then you have a stronger therapeutic alliance. So Jazakumullah khair for listening to me. Again, thank you for letting me see you, because it helps a lot. Otherwise, I'm just randomly talking. And I'd love to see the audience, if there is one there. You know how sometimes when we're talking, like, yes, you, 17th row from the 500th in the back, but really there's like 3 people in the audience. You don't have to show the audience, but I would love to see who I'm actually speaking to.
All right, Dr. Qasqas, so I'm just gonna play around with this a bit. I don't know if you can.
Oh yeah,
see this.
Here we go. Here we go. I can't see anybody.
All right, hold on, give me a second.
Assalamu alaikum, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakumullah khair for being here. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.
Assalamu alaikum. I will kill my screen. Actually, I'll stay on the video, but I'll kill my audio. Thank you.
All right, everyone. So thank you, Dr. Qasqas, for an amazing, amazing session. I wish that could go on forever, but we do have to move on to Q&A. Lots of inspiration from me in my own clinical practice myself. But if anyone has any questions for any of our esteemed speakers, online audience, I requested you deposit it in the chat box. If someone asked a question earlier on, I apologize. We're like flooded with like messages. So I humbly request that anyone who had a question, like deposit it again, like right now in the chat so that it comes up, like so that I can see it right now. If anyone in our live audience has any questions for any of our esteemed speakers, I humbly request that they write it out on this card paper, and then I can read it out to the speaker, inshallah. Does anyone have any questions?
She's ready.
Okay. Anyone else? Okay, we have. I saw some questions in the chat box. Okay, so Assalamu alaikum. Was wondering about whether we'll be provided with the slides from today's sessions. It's okay from my end. I leave that up to the discretion of the presenters. If they're okay with it, if things give me a thumbs up, if they're okay with their slides being shared. All right, Dr. Islam is up there with a thumbs up. All right, I see it. All right. Do we have any more questions in the chat? Let's see what we have. Okay, so Ms. Misbah Alam asked Dr. Qasqas, and I hope I'm not butchering the pronunciation of your name, sir. Do you have any resources you would recommend outlining the evidence-based approach that you mentioned? Dr. Qasqas, I leave you the floor to speak.
All right. Yes. So, well, no. Yes and no, because you have to go to multiple disciplines to do it. You got to go to the internationalization of products from, like, you know, when they globalize a product, it starts off with these essentials, and then they modify, then they localize it, right? So imagine doing something like that. And I know you asked about readings and stuff like that. So my first answer is I don't. I'm putting together the you know how, sorry, let me go back to basics here. Not Yaqeen's basic model, but different type of first principles here. If we look at ontology and epistemology issues in Islamic psychology and Muslim mental health, we're neglecting methodology issues. How are we actually arriving at these things, right? So when it comes to connecting Islam and psychology, or Islamic concepts to evidence-based practices, it's going to be very tough. You can't use concepts like concurrent validity because that's measurement, right? And at the end of the day, some of the constructs that we're trying to measure, we're still actually trying to develop construct identity. We're in what Thomas Kuhn calls the pre-science phase, right? So tons of ideas. This is awesome. This is amazing. It's like a shura process. So the idea is there has to be a different type of methodology to ensure that there's qabul and a certain level of acceptance, right? Just to get started. I don't mean uptake. I don't mean that it's better than others. I mean, do we accept it? So I have something I call the 40 hadith methodology method. So after I've completed something, I pass the 40 hadith with some explanations to a group of imams and scholars. this is something that I want to formalize a little more, because it would be amazing to get opinions from a very diverse set of scholars. And I don't just mean Hanafi, Hanbali, Shafi'i. I mean Athari, Maturidi. I mean at the Aqidah levels, Sufi, Salafi, Ikhwani, Tablighi, Tahriri, all of it. What represents the global Muslim opinions, right? And then the at least the level of acceptance from an Islamic perspective is there. With respect to acceptance from a secular perspective, well, that's where we go to the evidence-based literature, specifically the biological basis of behavior, cognitive basis of behavior, affective basis of behavior, social and cultural. That's what my field's all about, psychology, right? But the idea is, if it doesn't have ecological validity, if it's not relevant to a specific group, then what's the point? And that's where localization comes in. That's where bringing in total insiders, not just partial insiders. I mean, total insiders to give their feedback on it. So, sister, I'm so sorry. I know I should have just said no and moved on, but I had the opportunity to just kind of share the nuances and the depth that's going on. And again, mashallah, a lot of you are already doing a lot of this stuff. I would love nothing more than a collaboration, because we only have so many minutes and kilojoules in our lives left, right? So, jazakumullah khair.
So we only have about 10 minutes left for the Q&A, and I humbly request that the presenters, if they're comfortable with it, deposit their emails in the chat box, if you guys are okay with it for future questions. I leave that up to your discretion. But in the meantime, I want to move on to a question for Dr. Islam. The question is, Dr. Islam, if you're with us, did your research find that uncertainty and tolerance can exist independent of religiosity, more as a consequence of trauma or genetic predisposition? If you could shine some light on that, we'd appreciate that. Thank you.
Mashallah, no, it's an excellent question. I actually just messaged back that, subhanAllah, in the present analysis, that was not something that we could actually parse out or figure out from the data. But inshallah, absolutely, future research that's needed. SubhanAllah, absolutely. Excellent question.
Jazakallah, thank you. So there are two questions. I'm going to tackle both of these because they overlap strongly. So there's a question in the chat that kind of overlapped with a question from one of the audience members. The chat question was, please give us some examples. This is Brother Qasqas. Please give us some examples of how you use humor with Muslims in a therapeutic session. And I want to kind of tie that into a question from an audience member. And she asked, how do you go about building therapeutic alliance when you work with someone from the opposite sex using humor? The audience member says that she's an Arab-speaking clinician, so even if clients prefer a male clinician, she's the only choice, and sometimes it is awkward due to religious and cultural factors. So Dr. Qasqas, if you could shine some light on those two kind of interwoven questions, we'd appreciate that.
First of all, even talking about like presenting on humor, well, what if I'm not funny? I've just lost everything. It's like a guy talks about, how to get 1 million hits, and then on his Facebook page, it's like 30 people. So the idea is humor is subjective, right? But there is the aspect of novelty, like just getting shocked. You expect something to happen. So uncertainty is really low. You can predict there's boredom. Too much uncertainty, too high, that's fear, right? So that uncertainty, anxiety mix, إنما شفاء العي السؤال. You destroy that ignorance by asking questions, right? So the idea is, as you're engaging with somebody, you it's more of an art than a science. So instead of thinking if then, you have to start thinking when then, right? Like when this happens, I'll do this. When this happens, I'll do this. When this happens, I'll do this. So for example, I mean, with some people, I might say, look, with one person in particular, and this is very nuanced, she started going, because there's certain times where you have to challenge, certain times you validate. And she went off topic, and part of the idea was her focusing on the issue. And I said, "Isma'i, ana mish jartik tashkili." Okay, let's get back to the focus. In Arabic, that's, I'm not your neighbor to come complain to me. She died laughing. Others, for example, after giving the literally 10 minutes of connections and propositions, I'd say something like, this, all this to tell you this. And so the idea is it's that interaction, right? Now you said, how do I use that kind of stuff when I'm a female, they're a male? See, that's another aspect of it. In certain cases, humor is not okay. Like I rarely use humor with younger females because you never want to cross the boundary of familiar and friendly. With older Arab women, oh, they love it. They think I'm flirting, so they love it. You know what I mean? So, but again, it's a relationship thing. And really, I would love to say I tell you exactly how to do it, but then I would be A, lying, B, violating every single aspect of my being, which is adapt to, you know, different things. But the nuances is a different story. So my suggestion when it comes to being a female working with a male, or some of the other questions like any reluctance or reactance, you might have to fall back on your professionalism. In other words, ana doctora, I'm the doctor, you're coming to see me. That's already ingrained in their mind as acceptable. But that's a cultural adaptation. That's not a religious adaptation. For the religious side of things, yeah, there might be some barriers that you just gotta figure it out. I hope that's an acceptable answer, a certain level of qabul.
Jazakallah khair. I think your advice just to like play it by ear, you know, it really works. Do we have any more questions from anyone? Yeah. So do we have any more questions from anyone in our live audience or our, sorry, just Dr. Qasqas, give us 1 second. Did you?
Assalamu alaikum.
All right, we have someone.
Assalamu alaikum. Sheikh, can you please answer the question by Sister Fatima on the group chat?
Sure, what's the question?
Let me go check. It says, how can you convince the person that has big mental health issues to seek professional help while they solely believe that Islam is the only remedy and refuse to seek treatment?
Oh yeah, yeah. Oh wow, this is a whole nother conference topic, but this is where cognitive restructuring of the Islamic variety comes in, right? So for example, you got to understand why they believe that it's haram, for example, right? So let's say a lot of young people are saying things like, I know it's haram to be depressed. What do you mean you know it's haram to be depressed? How do you know? This is where it is a lot better to focus on the solid aqidah aspects. Like, listen, you really think that Allah is going to punish you for being sad? Well, what about all the ahadith on Allahumma inni a'udhu bika min al-hammi wal gham? What about Yaqub alayhi salam? He cried himself blind. What about Yusuf alayhi salam, betrayed by the very same people that were supposed to protect him? You telling me he was happy in the well? And the idea is you got to understand what the reactance factor is all about. What is it that they feel is dangerous such that they're avoiding that altogether? Because remember, sometimes it's actually cultural, not religious, in the sense that, well, I don't want people to know that I'm an idiot and I beat up my kids. Therefore, it must be haram to go see somebody. Other factors, they don't trust the whole profession. Why? Because they're worried about child family services. A lot more than the stigma of mental health. The other thing is, one of the reasons why I don't dig into that question much is because, well, they've already came and to see me, right? When the imam tries to convince them, go see a therapist, it comes off as forced sometimes. Okay, like, no, go see the therapist. But when the psychologist is actually giving the khutbah, that's why multidisciplinary teams where you have lay counselors who are trained in, I call it the Sunnah-based practice framework, others call it something else, but the idea is everybody is familiar with how this all works. The other thing is co-professional practice is something that's only starting a little bit of research on. How do you take a religious professional and a mental health professional and have them work collaboratively? CBT, the religiously adapted version, read it. Read the handbook on religion and spirituality from the APA and look at the chapter on Islam. Then compare that chapter to the other religions. You'll see what I'm talking about. You have partial, I'm sorry to say, but partial insiders talking about Islam with no references, with no authenticity. The same thing. The idea here is, from one of the essential characteristics and ethical factors, leave what doesn't concern you. And at the end of the day, if you're not familiar, if somebody's not familiar with an area, you got to find somebody who is. But look what's happening. We're all working on these silos. And as we're trying to develop this Muslim mental health and Islamic psychology and all that, instead of building bridges, we're all choking on the smoke of our own burning bridges. We're challenging imams, we're challenging this. Why? Let's just see what works, start with that, and then later we can come into what is better. But right now, at least in my city, I mean, I've been spending many years on this, right? So most people know who I am. Wallahi, I'm not trying to brag or anything like that. They do. So when they associate psychology with me and they trust me, then it's no longer an issue. The biggest issue, they can't afford $200 for a 50-minute session. So we also need lay counselors for that too, right? So Jazakallah, I hope I partially answered your question. And thank you for calling me Sheikh, but I'm not a Sheikh, brother. I wish I was. I'm only 42.
Shaykhun Kabir.
أعوذ بالله من الشيطان. استغفر الله العظيم. أفتنتني يا رجل.
MashaAllah, mashallah. Very good, mashallah. Jazakallah khair. Because I was going through a similar situation, so I wanted you to answer that. But yeah, Jazakallah.
There you go. Thank you.
Jazakallah khair, and thank you to all of our esteemed panelists today. And it was insightful, it was humorous, it was intelligent, and we're all super grateful to have had the opportunity to learn from all of you. And I see some emails in the chat. I'm sure our participants will look forward to kind of corresponding with the panelists moving forward. And I will work on the presentations for the panelists who've consented. With that, we're gonna have to wrap up this session. I had a blast. I don't know about you guys. It was really, really fun. And I'd just like to say a heartfelt thank you from our team at the Muslim Mental Health Conference. And we hope to see you all again next year, inshallah. Jazakallah khairan. Thank you. Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
Thank you. Thank you.